All right, so the little study guide I'll share with you. Okay, with recording. Okay, so yeah, so I'll share the study guide with you, and we'll add to it now in the next hour or so, and we'll go over whatever you've had on your agenda. So where's my markers at? Some people had a few things they wanted to go over. We'll write that on the board right now. And what do you want to go over that you thought about that you want to talk about? Sure. You don't at all. It's to help you understand the stuff. All right. It's to help you understand, and that's even if you spend an hour learning it, it's going to click. It's like, oh, that's why I test this one. That's why I look at that symptom. That's why I have this treatment. Right. The treatment is supposed to fix the patho. Right. So that's the goal, and that's my style, is to make sure understand the symptoms. Right. Because it's not going to. Yeah. I'm not going to test you on like which enzyme converts FTHF4 to whatever. No, that's not what I'm going to test you on that. But if it's like in Paget's, right, they have those two little things, little collagen fragments that you have to know, and what else is specific? Like what's the one I'm thinking of? I can't think of. One of them was osteo, where they have to know the different, like iron, for instance, right? You have to know all the different iron pathways, but you have to know that TIBC is elevated in iron deficiency, and so is the RDW, or sorry, what am I thinking of? The transferritin, right? It's gonna be elevated because, and then I hopefully explain the reason why, but you don't have to know the reason why for the test. You just have to know the answer, okay? Because adults learn better when they know the reason behind it, right? It's not very paternalistic to say, hey, this is it for 75 disease processes, right? So you have to know the why behind it. It's going to help you. If you don't know the why, when you look at it later, maybe the why will make sense. Oh, that's why that lab was elevated. That's why the alk phos was elevated, right? But you don't have to know that alkaline phosphatase converts this to this in the Krebs cycle and such. No, you don't have to know that. Okay.
Just have a generic question. For the chemo meds, I know you were saying the is it the alkaloids and the alkylating agents that get heat? Or is it just the vinculates that get heat?
I think it was spoken, like the slide is incorrect for that, for the extravasation, right? So extravasation is just the vincristines, right? Yeah, they're not alkylating agents. They are, what are they?
They're the
vinca alkaloids. So and yes, that's confusing. So that's why you just say the ones that have a VIN, right? Vincristine, make it crispy, right? So it crisps your nerves, and also you need to use crispy treatment, right? And crispy creams. So to make sure that you use heat, that's the only one you use heat for, right? And you use also H heat for hyaluronidase, right? All right, general cues and topics. What do you want to talk about? What do you want to focus on? I can just start talking, but I want to make sure it's your time. We'll try to go back to these things at the top of the file here.
For the antibiotics, are you going to want to know like the most common bugs where it's like gram-negative, anaerobes?
That's to help you understand. So like there's gram-negative bugs usually in the GI tract. So we're probably going to give an antibiotic that covers gram-negatives, right? And gram-positive bugs are usually on the where? On the skin, right? So you're probably, if you have a skin and soft tissue infection, you're probably going to give some things for gram-positive. You're probably going to think about the worst gram-positive bug on the skin, which is what? MRSA, MRSA, right? So we're going to give vancomycin, right? So you might be giving something that's broad spectrum covering gram-positive, gram-negatives, but they might have the worst situation, which is MRSA, right? Especially if they have risk factors. What are the risk factors for MRSA? That's like complication of. Where is it found? Risk factors. I didn't put it here. I need a higher surface. What are the risk factors for MRSA? And then therefore you need to get a MRSA swab, because usually an ICU swab everybody because they might have MRSA because they're coming to the most serious or most critical piece of the hospital. So you want to make sure you cover for that. But who else is high risk and should get a MRSA swab just on the floor as well? What's that? Well, they can develop MRSA pneumonia, but like who's at risk? MRSA swab everyone at risk, right? You got dialysis patients, homeless patients, right? People in group gatherings, right? Those
People
are
with a
patients that
history of MRSA?
history of MRSA. Good. You can add that to there. They have MRSA, the history, and it's probably because they were dialysis or hospitalized, right? Hospitalized recently. All right, so those are things that we'd want to make sure that, oh, I should probably do a MRSA swab, right? It's a basic thing, and also they should be on the antibiotic. That's the reason why they're getting this vancomycin, is because that's for MRSA, right? Vancomycin is what treats our MRSA. Let me zoom that in. So that's one of our MDROs, right? So MRSA, and how do you treat it? So the number one medication we're going to use is Vanco, right? That's going to be what you're going to be geared towards. There's a lot of things that work on it, which is good, because otherwise we can get what's called Versa, but that's not on the test. But you can get resistance to vancomycin for other things, right? Vancomycin resistant enterococci, right? But I thought vancomycin didn't work on the GI tract. It doesn't, but you're still taking it, and other gram positives are going to get eliminated, right? That's what the VRE is down here. Okay. The VRE, you got C. diff and MRSA. Those are your gram positives. So it makes sense that Vanco should work for all of them, but not for VRE because it's vancomycin resistant. But Vanco works for C. diff. Vanco works for MRSA because those are gram positive bugs. So that's why I'm telling you the bugs. So if you're a micro sleuth or micro aficionado, it's like, oh yeah, that's what that works for. That makes sense, right? It's just supposed to be a reminder from your micro 2 to 10 years ago. Okay. What else? You still want to talk about antibiotics? I can talk about things forever. Just let me know. So MDROs, so like MRSA, how do you prevent it? Well, you got to swab for it, right? And you got to find out who's high risk. MRSA pneumonia is extremely what's the word, invading, it's aggressive. So that's why we cover for for broad spectrum coverage, we're going to hit them with Vanco just because that they might, if they're really, really sick, that's probably a good option, right? So for broad spectrum coverage, you're doing gram positive, gram negatives, right? If they're not that sick, like ceftriaxone, which is a beta-lactam, that's perfectly fine, right? A little baby beta-lactam. If you want a big boy beta-lactam, you use what? Carbapenem, or you would reserve that, right? That we want to kind of save that in our back pocket just in case Zosyn doesn't work. Zosyn is very strong. All right. You don't have to know like which one's strong and heavy, but usually ceftriaxone is a broad spectrum beta-lactam, and then we'll hit them with Zosyn next if they're really sick, and then we can even escalate that to carbapenems if they're even more sick. All those guys are gram positive, gram negative. Not all of them cover Pseudomonas and anaerobes. That's what the last two do. But then we hit them with Vanco also, because all three of those guys just said cover gram positives, but we're also going to cover just for if they're really sick and broad spectrum wise, then they should probably get some Vanco coverage too. And how do you know they're really sick? It's a good segue. Just keeping track. It's a good segue right here, right? Good segue for severe sepsis or multi-organ failure or septic shock, right? Those guys probably need the heavy hitter antibiotics, right? So you want to know which stage they're in and like who's the priority patient to see. So if you have 4 patients, right? You have 4 sets of labs, you have 4 sets of things going on. Which one's the patient you should see first, right? The ones multi-organ failure, obviously, right? So if you have a patient that's alert and oriented, and a patient on a ventilator, obviously, it's a patient on a ventilator, they probably have an organ that's failed, right? But this would be more like labs, right? Lab-wise, right? So what are some labs that are affected? So lactate for sure. Right, so I didn't really go into this too much when I was putting this together because we kind of had a quiz on it too, but yeah, so severe sepsis, one finding, right? You got one finding of what? Of labs, right? So looking at labs here, diagnostic tests, right? So what we say for labs, you got lactate for sure, right? Greater than 2, right? Greater than 4 means what?
Severe.
Right, greater than 2 is already severe, right? Because that's the finding. But what else? Other labs, you just kind of go head to toe. You can draw a stick figure and go head to toe and think what can be damaged, right? So that's not head to toe, but okay, we'll go middle outward in concentric circles, right? So yeah, so kidneys, right? right? So that's what creatinine, right? Creatinine being elevated, right? You can put the values here if you want later. All right, creatinine, what else? T-bili, right? We are going concentric outwards. All right, T-bile. What else? What is it? Coags, good. So that could be your liver failing, and T-bili could be your liver failing also, but this could be your hematological failure, right? Because one of our consequences of MODS is, or one of our organs that are going to fail is which organ? Or that you don't kind of associate with organs because it's circulating in the bloodstream. The brain's not in the bloodstream. Be the hematological system failing, right? So that's like DIC is a complication of sepsis. That's one of your organs that can fail. Your brain can fail, your lungs can fail, your liver can fail, your kidneys can fail, and your hematological system can fail, right? Because you're using up all the clotting factors because you're making so many clots with DIC. That's kind of attached to sepsis. And no, you don't have to know the complement system or the cytokines or interleukins, right? But I bring up the interleukins and those things because, like with RA, they're stopping a specific interleukins that are triggering things. They're stopping the B cells or stopping the T cells, right? Same thing with lupus. All right, so that's severe sepsis and septic shock. So you want to know like your labs, et cetera, that are going to be affected, right? So identify like a priority patient. I think I might have put that there, right? Identify priority patient. But there, it's right there, right above it, one line up. Okay. All right, what else? You want to keep talking about sepsis? All right, what else? So sepsis and antibiotics, right? That's why we got a big right here. Yeah, short test review. What else you want to go over? I'll keep talking about random stuff, but I want you to be effective for you.
Professor, I did have a question going back to the MRSA medications.
Yes.
As I was looking back, you have Cipro down as one of the treatments, but I thought it was clindamycin. If we could just clarify it.
You're right, actually. I was thinking just C's. Let me just find that. Clindamycin. Thank you.
Okay.
I was trying to hurry in the last couple minutes. Because Cipro is indicated because it's you could think of C as a ciprofloxacin, right? Because fluoroquinolones are attached as causes of what? This guy right here, right? C. diff is caused by fluoroquinolones, cephalosporins, clindamycin. Thank you for clarifying that. Yes.
The pharmacology, are you supposed to know what class they are, or just know like what stage of the cell they're working with?
So what stage? Yeah. So you want to know what for chemo? You want to know the the stage of the cell, what its function is, what its action is, but also the side effects are going to be more important, right? You want to know what the side effects of those meds are, right? So chemo drug, I didn't do this one, but chemotherapy, right? Right, so you want to know the different agents, right? So you have alkylating, and which is a big class, right? You put the different tips there, right? And then just like you do it by stage, or you can do it by class, but the idea is to know the side effects, right? Right? And lesser so the stage it works in. All right, but the side effects, and then there's also the chemo, which is the chemo man, right? Which Jules drew a picture of and put in the exam 2 study tools, right? But we also have, you want to know like the, what is it? The thin chemo man. I don't know a better name for it. Like the general chemo symptoms, right? General side effects. Right. So if you have a little, it's one of the slides, like the second or third to last slide. So going head to toe, what are some side effects?
Alopecia.
We'll go head to toe. And then yes, nausea, vomiting. And we had some RX that we could give there. We had some, meds we could give, right? Okay. And then what's next? They got the mouth can get dry, right? Dry mouth or xerostomia. And then you had nurse interventions for each one of these, both, right? So like alopecia is just support and let them know it'll grow back. It might grow back different, right? If they had straight hair before, it might grow back curly. And then nausea, vomiting, we had different, interventions there. We usually pre-treat them with meds because we anticipate they can have like 3 days later, right? And what's on our chemo man up above, which one vomits a lot? The cisplatin, right? The platinum agents, all right? The cyclophosphamide does also, but that's kind of, and they keep going down, dry mouth. What else? What is it? Let's go to the we're still in the mouth and esophagus to get candidiasis. And how do you fix that? You do fluconazole, right? You can give the nystatin, right? And fluconazole is also attached to this one down here with neutropenic precautions, right? You should just start fluconazole if someone is really neutropenic. And what is neutropenic defined as? White blood cell count is low, but also we measure the absolute neutrophil count, right? And that's less than 500, right? And that's an easy math question, right? So neutrophils should be what percentage of white blood cells? 60, right? So never let monkeys eat bananas, right? So it goes 60, 30, 6, 3, 1, right? And neutrophils are 60%. So the white count is 1,000. The neutrophils are 600. Not yet technically, but we'll probably just do it anyway, in real life. But not yet do you have to put them in isolation, right? Not yet do you have to start fluconazole. But definitely if they get a fever, that's end of story, right? They're really, really sick at that point. If they have a fever, that means that infection can take hold immediately. The amount of neutrophils they have is literally 600, right? They have 600 neutrophils that are able to fight off that infection, right? But less than 500 is definitely concerning. And it's less than, that means it was like 800 white count and 60% of that is less than 500, right? So that being said, what are some interventions you would do? Yeah, no plants, no kids, no sniffles, no nothing, right? No berries, no, all those things, right? I encourage my clinical group to draw a picture. If someone's artistic, you can draw someone walking down the hallway with a whole bunch of kids in front of them with sniffly noses, right? No masks on, right? That's in their hand, right? And they got a huge bouquet of flowers and someone else has a huge basket of berries, right? So those are things that you would not do. You could be featured. My next slide's next year. Okay. So what else? Like a student drew the Homer thing with the hypercalcemia, right? With the Mexican blanket. So what else? You want to keep on talking about chemo and oncology?
What about the detoxifying agents? We should know those too, right? Like the Mensa, amifostine, those things.
Good. So yeah, so under general, maybe, I don't know. There's other ones that are general too, like nausea, vomiting and such. But we didn't finish all these pieces. No side effects, and then know how to fix side effects, right? Or how to prevent. I guess prevent. So what do we say again? We got Mesna, right? And who else?
Amifostine, leucovorin.
Yes, I always forget how many syllables it has. Okay, and what's the L? All right, that's just thiamine, or sorry, thiamine, it's folic acid. All right. Yes.
I got it on like one of these charts and it said like orange at the end. I was like tetracycline.
Tetracycline.
Tigacycline.
Why did that mean orange?
It makes everything orange.
That's just like for family.
It's kind of like rifampin, yeah,
Okay.
makes everything orange.
Okay.
You know, pee, fluids, tears, everything, right? And good. What makes things red? Rifampin, right? Rifampin makes everything red, orange. It depends on your eyeballs, but yeah, it's red colored, orange color, orangey red, right? And is that life threatening? No, it's like an expected side effect. You take this medication, it turns red, right? So it's not essentially like life threatening. You have to notify your doctor, but it's good teaching, right? It's like, hey, your fluids might turn red, right? And they go to the bathroom after the visit, like, oh shoot, and they call you right back up, right? What else? So talking about TB, you want to go there? Rifampin, rifampin, right? Red secretions, not life threatening. Teach it. All right, so what's the 4, 4, and 2, 2 for TB? Those are the months that you want to do these, right? You can just the whole duration, 4 more months, I should say. So it's what we say again is it's 6 months total, right? So that's even confusing. So let's do 6. I don't know the best way. I haven't figured out just yet, right? Maybe 2 months of these guys, right? Or is it 4 months? What did I say?
6 months for the
And
rifampin,
then
so the rifampin, and then the 2 months.
Just 2 months total, right? So yeah, I don't know the best way to do that. So you're like, that's for active TB. We're not gonna get to like latent TB and HIV management and such. It's just longer, right? Usually it's like 9 months, might be 12. It depends on the infectious disease doctor and other risk factors, right?
Should we know the prophylactics for opportunistic infections
Mhm.
for AIDS?
Yes. So for AIDS, right, you have some opportunistic infections here, right? TB is on there. You got PCP, toxo, and MAC. And put add-on candidiasis, but we already kind of talked about that with chemo, right? But there's no like, I mean, I guess, but as far as like meds, those are the ones you should know the meds attached to them, right? And usually it's Bactrim. If you had to get a guess, you get a 75% correct, right? The other one is, it's also the backup to Bactrim, but it's also the treatment for toxo, right? So Zithro for toxo, right? And as if there's also a backup, Bactrim doesn't work, but Bactrim is for all those. You start them prophylactically, no matter what, right? Once the CD4 count is what? Less than 200, right? So that's the magic number, and that's what defines AIDS. AIDS is a CD4 count less than 200 plus what? An infection, right? And yes, an AIDS defined infection, operative infection, right? And there's 20 plus different infections, but these are the ones that I'm going to give you some, I want you to know those are the ones that are the most common and the ones that you should know the treatment for. And recognize the symptoms, right? So PCP is what kind of symptoms? It also has night sweats, kind of like TB. What else does PCP uniquely have? Has a really, really dry cough, right? Persistent dry cough, night sweats. It's obviously gonna have a fever, right? Flu-like symptoms. Short of breath, right? So an AIDS patient comes to you short of breath, right? CD4 count of 100 because they're AIDS, right? Dry cough, night sweats. Is dry cough, night sweats TB? No, TB is what kind of symptoms? They got night sweats, but what kind of symptoms? Hemoptysis, that is the defining difference. Hemoptysis. Right, just to reiterate that, so we got hemoptysis, not dry cough, right? And that's night sweats also. Who else can those are B symptoms, and then they're not called B symptoms, but they also are attached to leukemia. They are B symptoms, right? You get flu-like symptoms, and you get B symptoms, and you get night sweats, right? And the bone pain is attached to it as well, for your leukemias, and also for the B symptoms of lymphoma, right? What else? Leukemias. So which ones are the worst leukemias? The acute ones, right? They are the most aggressive. They're the most ones that don't know what they're doing because it's a proliferation of the young cells, right? And they don't differentiate and turn into the adult versions, which can actually do things, can actually fight off infections, right? So they're a high infection risk, they're a high bleeding risk. They also have symptoms of what else made the bone marrow. Well, that's a complication, yes, but what? Not leukocytosis, but yes, you're going to have elevated white blood cells. So you make white blood cells, platelets, and what else in the bone marrow? I keep hearing platelets. So you have white blood cells, platelets, and red blood cells, right? So they have symptoms of anemia, right? They have anemia symptoms, thrombocytopenia symptoms, which you know, right? That's part of platelets, right? And we have the purpura and the bruising and the no contact sports and electric razors and such. And then we have white blood cells going to be really high, right? And they're high, but non-functional, right? They can attempt to fight infection, but they can't. So they're high risk for infection, right? So the acute ones are the worst one, right? So you want to know what's different between them, right? So that little chart on the sign and symptom slide, you want to know like what's the difference, right? Which one's has the Philadelphia chromosome? Which one's the hour rods? Which one has thrombocytosis? It's the only one where the platelets are elevated, right? And CML is bad news because it can have a blast crisis and it can differentiate into ALL or AML, right? So it could just be sitting there for a long time, be asymptomatic at 20%, and then it can all of a sudden one day like, you know what, this guy's not treating me right, and then it goes ahead and divides into ALL or AML. Right? And the middle initial, the L or the M, is kind of what makes you decide which can explain some of your symptoms and explain what the diagnostic steps are, for instance, right? Because myelogenous, right, white blood cells differentiate into two categories: myelogenous and lymphocytic. And lymphocytic is your B cells and T cells, right? So you're probably gonna have B cell, T cell symptoms, right? Whereas your myelogenous can be just you're never, right? Not your LUT, but your monkeys eat bananas, right? So it's everything except for the L's, right? So all those are going to be proliferated all over the place, right? So you have high white blood cells and you have all these extra cells, and then your spleen's like, what the heck are these guys? Are non-functional. So what does your spleen do to them? It eats them, right? And all the parts get eaten, and your spleen gets big, your liver gets big, because the liver now has to deal with all the little parts, right? You get hepatosplenomegaly is common with all the leukemias, right? So when someone tests you, like me, or the NCLEX or something, they have to test you on what's different, right? You can't test you on what's the same, right? I mean, you can test like what would you find with leukemia? Yes, you would find hepatosplenomegaly, high white blood cells, infection risk, et cetera, which is important. But if we're going to differentiate and ask you questions, we're going to ask you what's different, like which one has hour rods, which one has Philadelphia chromosome, which one has elevated platelets, which one has, I don't know, which one can have a blast crisis, right? Which one's the most asymptomatic? Right? But yes, your spleen's going to eat them. It's going to eat a lot of them. It's a crazy amount of white blood cells that are being made, right? So you're going to have signs of hemolysis or signs of tumor lysis syndrome. Which one? You have tumor lysis syndrome, right? And what's the difference between hemolysis and tumor lysis? Yeah, the fact that there's a nucleus, and when you break down nucleus components, you have purines in there. Purines, what makes up DNA and RNA. Half the story, right? You have ATGC in DNA and RNA, right? Pure as gold, AG are your purines. You don't really know that, but that was basic sciences. But those guys are getting broken down, right? You have purine breakdown into uric acid, right? And you use rasburicase, right? And allopurinol. There's no issue with your audio. It's just me talking weird. Okay. But yes, that's a good idea to know the difference, right? And with tumor lysis syndrome, we have the acronym PLUCK, right? And PLUCK explains your labs, right? You can explain symptoms too, right? Because if your uric acid is getting super, super high, what's that going to show? Some gout, right? So you get gout symptoms with high uric acid. right? And also you get high potassium, right? So that's kind of more of a final question. You got high potassium. Now you're going back to like high T waves, right? And you got some bradycardia and such. But for this exam, we got calcium being low. What's a low calcium look like? That's Chvostek and Trousseau, and right, because we have high calcium and low calcium that we can test you on, right? High calcium, not tumor lysis, but high calcium is what? They're usually thinking bone CA, right? And usually bone CA is due to metastasis, right? And you want to know the symptoms of high calcium, right? So good question would be, have the symptoms there and like which one is it, right? It's not going to be Chvostek. It's going to be if it's high calcium, it's going to be looking at the polyuria, incontinence, ALOC, et cetera. Okay. Is that good on leukemia or more on leukemia? Okay. What else? Sorry, the chat going over here. The chat just says yes. Okay. All right. Oh, I gotta take that away.
Hey, Grocers,
Yeah.
I got a question. You know how for like I think it's the Acinetobacter, the pan-resistant one? Will
Yeah.
one of the answers on the test be thoughts and prayers or no?
No. Well, yeah, that's just super resistant. You're going to be looking for some, usually carbapenems work. All right. You can go to polymyxins, but you got to recognize that we're taking out like the back pocket antibiotics that are like super resistant. But you definitely want to know what causes Acinetobacter, what causes Acinetobacter. Not washing hands is always the answer, right? To every single thing, but specifically causes who? What's a VAP? That's because it's from trach patients, vent patients, right? They like moist environments. All right, they're also kind of finding skin lesions and such. But what do you have to do for interventions, right? For all these little, for the MDROs, you definitely want to know PPE for each one. So if you haven't already made a chart for how you get it, what the treatment is, which can be detailed, but also what are the interventions I'm going to do? Teaching wise, right? Interventions always wash hands and foam in, foam out, except for which one? C. diff, we can't, it's only wash hands, right? Foam in, foam out is going to be ineffective, right? And also interventions could be like surveillance, right? You got to do a MRSA swab for MRSA, and you got to do an ANO swab for what? VRE, right? So as far as like interventions, we could look at PPE. What do you do for PPE for Acinetobacter? So it's contact plus, right? All right, that means we got booties and bouffants. What's a bouffant? That's a head cap, right? All right, so goggles aren't really necessary, right? It's not a droplet thing. It's a contact situation, right? And you can track it into other patients' rooms and get them infected, okay? So yeah, so another PPE between them, all right? So you got other enhanced PPE. Who else has enhanced, not enhanced PPE, but enhanced isolation precautions? Is C. diff, right? C. diff has isolation, you have enhanced isolation. By enhanced just means you wash your hands, you don't foam out, right? And you don't foam in either. Okay. And then like to take us to the next level, other PPE, right? Other enhanced PPE would be what? Not MDR related, but related to like leukemia, for instance. Neutropenia precautions, right? All right. I guess I wouldn't technically be neutropenia because you wouldn't have neutropenia. You'd have neutrocytosis or leukocytosis. Either way, they're high risk for infection, but definitely if someone has a low white count, right? We're going to hit them up with what's precautions we mentioned already. Yeah, no fruits, no berries, no people, no yes masks. Okay. What else? So that kind of talk about chemo and leukemia and those guys, right? So there are different other topics. You got musculoskeletal, right? So you got sepsis, TB, we're talking about hematology a little bit, and then musculoskeletal, right? You can split that into two sections, bones and non-bones. Yes.
Kind of your comment about kind of and the illnesses and their symptoms.
Yeah, so as far as like what we test on, is like that's from the syllabus, right? You have to know the causes, you have to know the treatment, right? And treatment includes non-pharmacological, which is nursing, right? What I can do as a nurse, I can do weight-bearing recommendations. Who gets weight-bearing recommendations? Weight-bearing exercises. Osteoporosis, right? Who gets weight, what's the word? Non-weight-bearing exercises. Osteoarthritis, right? Because osteoarthritis has to lose weight somehow, right? So they have to lose their weight with not putting more weight to cause more symptoms, right? So you have to know the causes and the symptoms of diseases and the treatment of the diseases, right? And then complications, because the complications usually lead to other disease processes. Okay, so that's kind of the goal for each one. And in class, I'm going to give you the reason why for each one of those things, right? Not just waste time in lecture, but just also kind of explain like this is, I'm not going to easily just say, hey, here they are. Good luck. See you Monday. But I want to give you the reason why for each one. Okay, does that make sense? Does that answer your question?
Yeah, it's just that everyone's like here, it's like, oh, just need meds. They're like, it's gonna be, I don't know.
No, meds are only like what 18-20%, whatever it is for the NCLEX plan.
Oh, is it really? Okay, cool.
Yeah, there's a lot of meds because there's antibiotics and there's an oncology, yes. But we have to get it to you somehow in one of the 3 MedSurg classes, right? MedSurg 1 is all about cardiac meds, right? This class can be about the antibiotics and chemo meds. Next semester, like vasopressors and other fun stuff. Reversal agents, toxin reversals, emergency meds. All right, so we have to get it to you somehow. So about 20%, 10 to 20% each test will give you some meds. So you have to know those meds and what their side effects are. That's the most important, and especially if it's a life-threatening side effect. But also, you want to know nurse interventions, what to monitor for. Because if a medication is causing thrombocytopenia, we should know what that looks like and make sure we teach them to avoid those things. And that's kind of carrying over from MedSurg 1. We talked about, they're on aspirin and such before. Right. So you're looking at meds, you want to look at side effects. I give kind of little tables for each section, like what the side, so you can identify side effects. Identify usually the top of the tables is usually what's most commonly prescribed, right? And at the bottom of the tables is usually for like advanced disease. Things don't work good, right? Like rheumatoid arthritis, they're really switching over to the 2nd level DMARDs, right? So you have DMARDs, you got HARTs. Who are HARTs for? Highly active antiretroviral therapy, HIV, right? And then DMARDs, they separate into synthetic and non-synthetic or biologic, right? And the nice thing about the DMARDs is there's overlap with lupus. So once you learn them once, there's a lot of overlap. They both have steroids. One of them has steroids for forever, but both of them have hydroxychloroquine. Both of them have methotrexate, right? So we're kind of starting on either 2 or 3 of those guys all at once, right? Those guys are getting combo drugs all the way through. And then we could keep adding MABs and such. And those are where all our MABs are, except for our this guy right here, denosumab, right? He doesn't belong to lupus. He doesn't belong to RA, right? He doesn't work on the inflammatory responses like interleukin 1 or 6 or CD4 or TNF alpha. He doesn't work on those. He works on what? He works on D bones, okay? So he works on D osteoclasts specifically, with some rank L, and stops osteoclast proliferation. And osteoclasts are causing problems, right? They're the ones that are increased with inflammation, and they're also breaking down bone, right? And we want to stop that with osteoporosis. We want to stop that if we have bone cancer, right? And we have to stop that we have metastasis to the bones that are causing breakdown of our bones. These osteoclasts are breaking them down. So denosumab is going to help with that. Right, so denosumab is it's an emergency med also. So it has super high calcium, right? And what's a super high calcium? More than 10.5, but definitely more than 14 for sure is going to be a bad situation. That usually means cancer until proven otherwise. That's usually what it means, right? And what other disease process likes to metastasize the bones? That's white blood cell related. Causes lytic lesions on x-rays. Multiple myeloma, good. Right, so remember BLT with a kosher pickle, right? What's the acronym? I didn't put it here, but multiple myeloma, I think, was on that list. Mustard mayonnaise, right? Okay, I forgot the mustard mayonnaise with the sandwich. There's the multiple myeloma, kosher pickle and mustard mayonnaise, right? So yeah, multiple myeloma can metastasize to the bones and cause a hypercalcemic crisis, and we have to give denosumab, and we have to give the IV. What are these guys? What are dronates? These are IV bisphosphonates, right? Right? And we give those guys are for a hypercalcemic crisis. And why would you have a hypercalcemic crisis? Because you have metastasis to your bones, right? And also, ironically, if someone comes in with Paget's disease, you can give those guys as well. Okay, that's usually when they come in, they're having like severe pain, and they're having like pinched nerves, causing blindness and hearing loss and all kinds of other bad things. Okay, what else? So sickle cell anemia question. So what is sickle cell anemia? It's inherited, right? It's autosomal recessive, right? Knowing the cause of the crisis, right? It's probably not just going to say hypoxia or acidosis. You got to recognize, what does acidosis look like? What does hypoxia look like? Who gets hypoxic and acidotic? That's usually an infection. Infection is the worst news for a sickle cell patient, right? Especially if it's a what kind of infection? Especially if it's I thought I put it here. I didn't there. A pneumonia, right? A lung infection is the worst thing, right? That's called acute chest syndrome in the sickle cell community, and that requires emergent treatment. That's a red flag, right? Also, what else is a red flag? Fever. I'm gonna put that somewhere. Avoid infection, right? Fever equals very, very bad, right? Because infection is always what we want to avoid. So that's good teaching, avoid infections, and also make sure they're taking their vaccines, right? And how many vaccines do they take? At least how many? At least 3 vaccines for sure. They hit the Haemophilus, Streptococcus, and their meningococcal. Okay. And then they're going to get COVID vaccine, flu vaccine, all the vaccines except the vaccines that are live, right? So like for status for sickle cell, teaching is important, but also vaccines and how to treat the underlying cause, right? Make sure they get what should get done for a sickle cell patient. To treat the infection, you got to give them, well, if you know the hypoxic causes sickle cell crisis, you should probably give them what? Oxygen, right? And they have severe pain. Usually the pain goal is like how many minutes? 30 minutes, right? And they have to get an exchange transfusion, which is different than a PRBC transfusion, right? PRBC transfusion is a treatment, right? You want to dilute the hemoglobin what? S, right? Dilute hemoglobin S. Right. So, but if they have a massive crisis when they come in, and by massive crisis, I mean a vaso-occlusive crisis that includes that acute chest syndrome. But what else? So we've got pulmonary there, and we got, I'm trying to come up with an acronym for that, or a mnemonic for that, but priapism, CVA, and retinal. Right. They started to say, I can't see. What's your history? Sickle cell disease. Come with me. Right. We got to do an exchange transfusion. Right. And what is exchange transfusion? They take all their blood out and replace with someone else's blood, about 5 to 10 units, right? Usually 5 units. All right. So a good SATA question is like, what are these treatments? Usually it's going to fix the hypoxia, fix the acidosis, fix the dehydration, right? Vasodilate, right? Versus vasoconstrict. The hydroxyurea is attached to sickle cell. Hydroxyurea, is this lupus that also gets hydroxyurea? Lupus? I don't know. I might be wrong. Let's see. I don't see it there. But hydroxyurea definitely attached to sickle cell. Yeah, it's considered a therapy drug, and it's used a lot with like bone marrow transplants and patients that have like leukocytoses and thrombocytoses. They say hydroxyurea is like a chemical shave. It just kind of lowers things. So it causes what side effects? BM suppression, right? It's going to lower platelet count, lower RBC count, and lower white blood cell count. So when someone has like polycythemia, which we did talk to you about, all right, that they have excess RBC, we give them hydroxyurea. Someone's extra platelet, we give them hydroxyurea. Extra WBC, give them hydroxyurea. But also it has this unique thing that it also causes hemoglobin F, right? Okay. So yeah, so with sickle cell, you kind of attach that hydroxyurea is attached to that guy. Would iron overload, yes, because they're getting like a significant amount. They're getting like hundreds of units. So you have to de-iron them, right? How do you de-iron them? Yeah, DFE. It's gonna have DFE in it somewhere, right? D-peroxamine, deferoxamine, and the other varieties of that. Right. All right, so you can just say stop, kind of like the Olive Garden. So you got platelets, all right, low platelets, right, and I'll give you all low platelet situations, right, and you can get low platelets if you bleed enough, and if you bleed it, why would you bleed enough? Well, you have like maybe hemophilia, right, that can cause it. So knowing like philiacs usually get factor bleeding first before they get low platelet bleeding, right? But going back, what's low platelet bleeding look like? I think I put it down here. They get platelets are low, so therefore you're going to start bleeding to the skin, getting what kind of symptoms? Purpura, right? You get petechiae, and they just straight up hematomas. And you get holy bleeding to the holes, right? So you just go head to toe, you got epistaxis, right? Mouth has 2 holes in it, right? 3 holes if you're fancy, but hemoptysis is your lungs, right? And you got gingival bleeding. And the third bleeding that comes out of your mouth is the most life-threatening, right? That's emergent, so we should probably put that in red. What's the blood that comes out of your mouth that is GI related, right? That is hemoptysis or hematemesis. Which one? Where's my colors at? There it is. It's highlight, but okay. So yeah, GI, intracranial hemorrhage, those are life-threatening bleeds. So you definitely need to fix that, but they need to report all these either way, right? So the nurse is gonna be concerned when you see these things. And when do these things usually happen? When platelet counts are when? Less than how much? Usually less than 100,000, you can start getting them anyway. Less than 50, yes. Less than 20, definitely they're gonna be spontaneous. Right. And the reason why that happened is they were getting medications that were lowering it, or they get a disease process lowering it, like leukemias, right? Except for which leukemia? Which one does not cause low platelets? CLL does not. Sorry, CML does not, right? The reason why CML does not is because it can actually, yes, it's usually the adults version of the cells, but it can make a U-turn and go right back over and cause elevation of the other cell lines, like platelets. Okay, so what's more serious, hematemesis or hemoptysis? Hematemesis, right? So yeah, if you start using all your platelets, you can start getting, using all your factors, you keep bleeding with hemophilia, you're losing all your factors, right? Yeah, factors, which factors are they? 8, 9, 11, right? And then if you lose all those factors, you're bleeding, you're losing platelets. That's the most common reason for your platelets being low, because you're bleeding. Right? But usually you're going to start having hemarthroses, right? And what's the bad thing about hemarthroses? They're deforming, so they have to get what to fix it? An arthrocentesis, right? Otherwise they'll get a deformity. And yes, you can start getting platelet bleeding eventually as you start bleeding and bleeding and bleeding. Right? If someone has life-threatening bleeding, what do you give? It is true for any situation, but we've kind of attached to hemophilia. You give TXA. You give the acids, right? Tranexamic acid and immunocaproic acid. And those are if they're hemorrhaging, right? All right, so that's platelets. I put DIC under platelets, but you can put that back up with sepsis, but you want to differentiate what does DIC versus heparin versus hemophilia look like, right? So I give you a four or five labs, right? For platelets. Obviously, the platelets are going to be low in every one of those situations, right? And then fibrinogen will be low in each one of those, right? Because you're using up all your clotting in pretty much all those, but your fibrinogen is low in hemophilia. Maybe it's borderline. But INR and PTT are going to be elevated, except for which one? Hemophilia, only one of those is elevated, and that's the PTT because of the way it works in the coag cascade.
What is the law for fibrinogen?
Fibrinogen less than 200 is bad. But yeah, so DIC and a HIT, they have the kind of similar signs and symptoms, right? They have clotting, so they come in with gangrenous fingers. They come in with all those bruising, and they might come with a stroke or a heart attack or clots, VTE, right? A venous thromboembolism. They come in with a DVT or they come with a pulmonary embolism, right? With DVT, sorry, with a DIC or HIT. But how you tell the difference is HIT, you can send these labs off, right? But usually DIC is like really, really extreme bleeding. Usually HIT doesn't have like the extreme bleeding situation. They do have the clot situation and a low platelet situation, but they're not like bleeding. But they're gonna have the signs of low platelets, which are, the skin bleeding, the holes of the bleeding. Right, and then HIT, you have the fancy designer anticoagulants, right? Because people still need to be on anticoagulants in the hospital. And just because they have HIT, you gotta say, well, you gotta move over to these guys, right? Fondaparinux and apixaban. Anybody see that in clinical? So apixaban. Those are non-heparin containing medications, right? Does enoxaparin have heparin in it? Yes, it does. So don't give it to someone who has a heparin allergy. You want to think of it as an allergy. And it's kind of like rheumatoid arthritis. You're forming an antibody against a heparin attached vector. So it's a weird conglomeration. Sorry for those on the audio. You hear all the markers moving, swishing in my hands. All right. Do you want to do another Olive Garden moment? Hemophilia, white blood cells, where the normals are. Never let monkeys eat bananas. Right. Leukemia, as we kind of mentioned. Complications we mentioned. Lymphoma, Hodgkin's versus non-Hodgkin's. Multiple myeloma. Oncological emergencies. Now that you revisit it, spinal cord compression should look now more familiar because that's just attached to lower back pain, right? And what's a bad lower back pain situation, right? This is the worst situation is you have a radiculopathy that's even more ridiculous, right? Which means you have a loss of motor and loss of sensory, right? What's a loss of motor look like? Paralysis, right? Radiculopathies, they'll have weakness, yes, but then it progresses into progressive radiculopathy or more ridiculous radiculopathy is paralysis, right? That's the worst you can get. And what's the worst sensory situation you can get? Not feeling anything, right? So you're not feeling and not moving. That's bad, right? And if it's due to a metastasis, like in multiple myeloma or bone cancer or whatever it may be, right? That can cause spinal cord compression, right? And you see that in oncology because that's cancer, right? So you got radiculopathy that's leading to like cauda-equina syndromes, right? So what is cauda-equina? Has spine as the acronym, as a mnemonic. You got S for saddle anesthesia, P for paralysis, right? So there you got anesthesia and paralysis right there. I is for what? Unable to use, unable to, yeah, they're incontinent, right? Have incontinence. Okay, and that's a neurosurgical emergency. You got to intervene immediately, right? If it's something that's stable, we can maybe hook them up with some radiation. If they're on chemo, we can have some chemo too to reduce it. But usually they need to get it fixed right then and there, right? And then bone cancers lead to what kind of fractures? Pathological fractures. Do I know what's different in a pathological fracture and who gets them, and who has regular old fractures? Who gets regular old fractures? Osteoporosis does, right? Whereas pathological fractures, who gets those? Bone cancers and PDB, right? And we talked about hypercalcemia. That's due to bone cancer, right? SVC syndrome is kind of its unique thing. It's usually with lymphomas or tumors that are near the SVC. Where's your SVC at? Point to your SVC. It's right there, right? So superior vena cava, and things are compressing it. So you don't get venous drainage, you don't get lymphatic drainage, you get lymph nodes that are increasing that side. You get facial edema and edema on that one side, right? All right, so say when Parmesan cheese, chemotherapy, chemotactics, right? Kind of talked about that. After you get chemotherapy, you might hit them up with some with these WBC stimulants, right? Because they're at risk for infection, and we'll hit them up with these, just like with erythropoietin. It's like this is erythropoietin for the white blood cells. What's the erythropoietin equivalent for platelets? It's kind of funny because it sounds like we're like toddlers speaking. So filgrastim is for white blood cells. What's for? And it sounds exactly like a toddler speaking too. So let's look at my platelets over here. For ITP is usually when you give those guys, right? I thought I bolded it. A trombopag, right? And romiplastim. Those are meds you give. So it's a simple chart, right? Say, okay, how do I stimulate RBCs? EPO. How do I stimulate platelets? Those two guys. How do I stimulate WBCs? Filgrastim. And the other one's pegfilgrastim. So it's pegylated, whatever. It's filgrastim, right? So when platelets are low and absolutely nothing else is causing low platelets, right? You don't just give this just because platelets are low. That means you've figured out everything else. They're not getting hydroxyurea. They're not getting something else is going to decrease bone marrow. They're not bleeding, right? It's like, oh, look at you, your leg's bleeding. I know, we'll give you romiflostim, right? No, that's the fixes to fix the underlying cause. They got hemarthrosis. No, you're not going to give this one. You're going to give and they're massively bleeding. If you're bleeding into a joint, by the way, that can compress what distally and have what kind of complications distally. If your joint in your knee is filling up with blood, your pulses not going to work, right? You can have vascular compromise, right? Who else do you assess? Not vascular, but assess the distal extremities for? Cow? Gout, distal extremities, but no, like distal extremities can get absent sensation and they can get absent movement. Lower back pain, good. So lower back pain and also the fix for lower back pain. What's the fix for lower back pain? Exercise is a good fix, but this is a surgical fix for lower back pain. You get spinal fusion, right, or spinal surgery of some sort, and then you're going to assess them post-op, spinal surgery wise, right? And you're going to assess for what? Distal extremities, they're working, right? This isn't really so much a vascular situation, but there's a little overlap there, right? So you're going to assess sensation distally, right, at the dermatome level. So you usually in real life also you just pull up your dermatome map. It's like, oh, your big toe should be working, right? You should be able to lift your left. You should be able to feel the back of your thigh. Right, so let's look dermatome, derma. Okay, so post-op, for someone that has a lower back pain, right? We're going to do the log roll with the log rolling. Learn that in first semester. So as a unit, right? You're going to move them all at once, right? Are you going to be bending the legs and turning? Not likely. Okay. Also, who else doesn't get bent legs and sleeping on the side? Huh? Joint replacements. Yeah, hip replacement. No more than 90 degrees, right? So mobilize both joint replacements and your back surgery patients, right? You're assessed for worsening symptoms. Worsening symptoms are never good with back surgery, with spinal surgery. They should always get better, right? And observe for, it says, I just interpret that as low back pain. It's low blood pressure. And to observe for low back pain. It's like, yeah, of course you would. All right, but yeah, you observe for low blood pressure. That means it's squeezing and squeezing. It's getting more and more edema post-operatively, and maybe more bleeding right there in the spinal cord where they did the surgery, and now not only compressing the nerves going to and fro, but it's also compressing the nerves going to the blood vessels, causing vasodilation. Okay, you assess the dermatomes, right? Specifically looking for sensation and motor. Okay. And then for joint replacements, TJR, procedure, contraindications, teaching, right? Sleep. What's the right way to sleep for someone who has a total hip? If you have a total knee, you can sleep however you want, but total hip, you got to avoid that 90-degree flexion, right? So you can think of as a chair mode as 90 degrees, right? You're sitting in the chair, your hips are flexed right there, so there should be more than that, right? Or not more than that, less than that, right? 75 degrees, 70 degrees, 60 degrees is good. 100 degrees, 110 degrees is not good. And then amputation wise, right? Then you get an amputation, right? Then we have to then think about contractures, right? You elevate their extremity for how long? Just 24 hours to decrease edema. Contracture interventions, right? Elevate times 24 hours. Sleep prone. So probably make a sleep table, right? Sleep prone. Who gets prone? Who does not get prone? Right? Make it 3 columns, right? So you have, you know what I'm talking about. So it's insert a table, table, like this, right? And we can put down who gets prone, right? So you can do a picture of what it looks like, right? You can do then you can do a much I say recommended for, not recommended, not for, right? Not for who? Lower back pain, probably not gonna be a good example, right? But recommended for amputations, right? And then you can say sideline, right? And then not for hip replacements if greater than 90 degrees, right? Or not 90 degrees, but what I'm trying to say, they can sleep on their, sorry, I'm thinking of back pain. But yeah, not for total hip replacement. All right, and then what else? Supine, right? Who should be supine, right? Etc. Okay. All right, do another Olive Garden movement. Okay, total joint replacement. Yes.
It's not a total hip replacement, but it would do for a total hip replacement.
Yeah, it's fine for total knee. Total knee, there's not as many recommendations. The recommendation is move. Right, so mobilize is the biggest issue. Even amputation can't really move that well, but for a joint replacement, you got to rely on the hip and the knee. But specifically for the hip, don't sleep like that.
Like
Is it abduction or adduction? So you want to add to the body, you want to abduct from the body, right? You want to keep the legs abducted from the body, right? So abduction pillow. All right, so for joint replacements, right? Pillows between knees, right? No leg crossing, home safety, right? Make sure there's no kids at home, right? They can be sniffly, that's fine. They cannot wear masks as long as they aren't leaving stuff out, right? All right, let's keep scrolling. Are you good? Are you saturated? RA and lupus, right? RA and lupus get a little fancy because they have a lot of, you got the white blood cells and inflammatory system at work, right? But definitely differentiate OA versus RA. Easy guarantee, it'll probably be in your NCLEX as well. It's just a very easy question to ask, right? Which one's symmetrical and asymmetrical? Which one is extra articular and articular only, right? Which one gets better with movement? Which one does not get better with movement? And that can be worded many different ways, right? Which one improves with rest, right? OA improves with rest, does not get better with movement. RA does not get better with rest. What am I trying to say? RA does not improve with, RA improves with movement, right? They get better throughout the day. But RA is still stiff throughout the day. Okay. You got meds, right? So you basically want to know like what you start them with. That's the most important part. And it's recognized like all those mAbs are all attached to lupus and RA, except for denosumab, right? Denosumab is up with the osteos and the bone CAs and the hypercalcemia. Right? Lupus, that's an easy picture question, right? Which picture is lupus, right? What's unique to lupus? Lupus and RA both have extra articular symptoms. They both have vasculitis. They both have eye problems, skin problems. They both have symptoms all over the place. Those are some things that are specific for lupus. And those are the questions you can ask, right? You can ask, do they have an anti-phospholipid or anti-RNA or anti-DNA antibody? That's unique to lupus, right? It's unique to lupus to have a butterfly rash, right? Or malar rash or the face rash, right? And they are, who's photosensitive? Lupus, right? They both have extra articular, but they both have arthritis. You can have lupus arthritis too. Either way, treatment is also combo drugs, right? And I add some other hemo drugs in there too. And then gout. What's that? The lupus starts with systemic SLE, you're saying, like systemic lupus?
Yeah. Because isn't it like one is like it gets worse then you go to method check date.
So yeah, lupus starts with hydroxychloroquine. That's its bread and butter. It's hydroxychloroquine. But you also start hydroxychloroquine with RA. But usually hydroxychloroquine, that's the one that you're really hitting with lupus, and you're hitting them with steroids. Usually with RA, you'll get them like steroids for like 3 months, and they don't need to be on steroids for life. Only with exacerbations, right? Anytime you have an exacerbation of an autoimmune condition like RA or lupus, you start steroids, IV steroids. But steroids and hydroxychloroquine are automatic with lupus. So when it gets lupus, they're going to be on those meds. Okay. And with the hydroxychloroquine being said, there's teaching, right? What do you have to do with that? Get eye checks, right? So you got eye checks, we got lab checks, right? Lab checks for RA and lupus because you're getting mAbs, right? Monoclonal antibodies. So what labs they got to check for those ones? Got to make sure they don't have opportunistic infections that will grow when they have these mAbs, right? Because we're stopping the immune system, right? So Hep B, Hep C, TB, HIV can all become reactivated. So eye checks, liver checks, that's methotrexate, right? And what else? So gout reminds me of diets, right? So you want to make a diet table if you haven't already. Like who gets a high iron diet, who gets a high folate diet, who gets a B12 diet. So obviously it's the anemias, but what's an example of, right? All right, so then also gout diet. What's a good gout diet? What's another diet out there? So let's put it here. So we talked about anemia diets, right? And when we say diets, we're talking about recommended for versus and treatment and examples of, right? So I usually give you like a top 10 for each one, like what has the most calcium in it, which one has the most B12 in it, which one has the most. So you want to know like the top 3 for each one of those, right? I'm not gonna give you like number 10. It's like, oh, look, it's Swiss chard. So it'd be like the top ones, clamshells. Right, but anyways, you got anemia diets, right? We got osteo diets. That means you're probably recommending what? Vitamin D and calcium, right? And you got gout diets, right? And we got what else? We got linezolid diets. What the heck? Those are MAO. Those are, what do we call them? Not MAOIs. We call them the aged and smoked stuff. High tyramines. Yeah, there we go. You know, low tyramine. Right. And that kind of overlaps in gout because gout loves to eat smoked game. Right. Any other diet you can think of we talked about? There's at least 2 or 3 diet questions about that. So they're like sharing their food diary. It's like, oh, that's not a good option, right? You're gonna stop that. Or they're saying, hey, can I eat this? It's my favorite. So nope, we got gout. Right. And with gout, we mentioned high fructose corn syrup and aspirin are not recommended. Aspirin is not part of a diet, but I'm just saying. Right. So high fructose corn syrup is not recommended. I thought I put that here somewhere. There it is, HFCS, high fructose corn syrup. Thank you, Google. I knew what HFCS was. All right, so that's gout, and then fibromyalgia. It's kind of not wishy-washy, but it's still important, but there's no like official diagnostic test you can do. It's all based on their symptoms. They got pain, right? And they got pain for 3 months, and they got pain during menses. They got pain that's out of proportion. So we have to give things that are stopping pain signals. And these medications we're stopping pain signals with are also for like lower back pain, right? Which are what? Antidepressants, right? I'm not sure if I mentioned anticonvulsants there also, but anticonvulsants are also with lower back pain. So fibromyalgia, lower back pain, amputation, also you're going to stop that nerve pain, right? What's that called? An amputation and nerve pain. What's that pain called? Phantom pain. And what interventions can you do for that? You can rapid press it, right? And also you can do CBT, and you can do what else? You give meds, right? Use mirror therapy, use VR and meta before you get laid off. Okay. And exercising, you can do whatever exercise you want for fibromyalgia, but there's just differentiating weight bearing versus not weight bearing, right? When we talk about exercise. So if you have like on your interventions section, like what do I recommend? I got diet recommendations I got to recommend for all these things. I got exercises I got to recommend, weight bearing versus non-weight bearing. What else? We have sleeping, right? I got to recommend for all these things. For OA, you can sleep however you want. All right, doesn't matter. But for like the back pain, it matters. For the hip replacement, it matters how I sleep, right? And for the final, for GERD, it matters how I sleep. Right? Is that good, or you want to keep going, or? I think we Olive Garden this the most, right? Let's go back up this way in case you see something you like. You guys all go study at Olive Garden right now. Scoliosis. Got some pictures of braces and what's what's recommended for scoliosis. What tells you have scoliosis? What are some status or symptoms that you have for scoliosis? Right. This is uneven. That's uneven. This is kyphosis and lordosis or not. Right. Orthotics and back braces. What else? This is osteoporosis. Osteoporosis we spent the most much because it kind of applies to everything else, right? As far as labs are concerned, right? So that can be a whole section just on labs, right? This is probably the most lab heavy test, right? You got labs for platelets and bleeding. You got labs for osteo. We got labs for sepsis, right? We got labs for HIV. We got labs for not really TB. Yeah, TB, but PPD is not really a lab, but right. To know your labs and how to say, well, oh, that looks like they have a sepsis problem, right? Because they got organ problems, got an organ situation, right? For osteoporosis, we're looking at, there's some antibodies here and there, but also they might have what other labs are unique to osteoporosis and for what's it called? For like PDB and for bone breakdown. Alk-Phos is the answer, but saying it again was what bone labs, right? Alk-Phos is a good one, right? You have excess osteoblast activity. Calcium will probably be elevated in some situations, right? And then like specific diagnostic tests like the DEXA scan and FRAX score for osteoporosis. So labs are important. And then so labs and meds, everybody's favorite. Oncological emergencies you mentioned, talk about lymphoma a little bit. Can you see it or is it too low resolution? Platelets, RBCs, we didn't talk about RBCs too much, but you definitely want to know what you got hemolysis labs, right? Tumor lysis syndrome labs, what the difference is, right? These guys are not going to have what that's elevated with hemolysis, what will not be with RBC labs, hemolysis. Uric acid, right? Purines, that's nowhere to be found because our RBCs are breaking down, right? We will have LDH, that's in both, right? So it's just to a quick table, what's the difference between the two, right? And who gets it, right? So examples of, right? And of course, diets, right? Like which diet gets vitamin C? Iron for sure. Folate, it might help, right? But definitely iron is a vitamin C. We talk about TB and HIV a little bit. Talk about so PPD, some pictures of some indurated erythematous bumps and some measurements, and which one is concerning, right? So a nurse should not have a PPD greater than what? Greater than 10, right? So at-risk people, not immunocompromised. Immunocompromised is greater than 5, right? They have like no white blood cells. They got an ANC of 600. They don't. It's impossible for them to get the 10 millimeters, right? You would use all of their neutrophils, and if that was the case, right? So that's why they just get 5. But someone like us, that's an exposure at risk, right? Someone that works with these people, they are 10 or more is concerning, right? If you are not a nurse, there's no reason for you to be exposed, for you to have any risk factors. That's 15, right? HIV, AIDS, and then back to our MDROs and antibiotics. So our agenda was antibiotics. Do we meet that agenda item? All right, so I'll copy this. I can copy it now if you want. If you're going to Olive Garden, you can review it. And then otherwise, at the end of the day, I'll upload a updated version after I've gone through and made ExamSoft work for me. So last time I did this, I battled with ExamSoft for a long time. So hopefully it's not as big as a battle, all right? And I'll update it with things here and there. Okay, is that good? Any other last minute questions?
Okay, so this is not available to us now.
Oh, I can put it now.
Oh,
So let's make a copy of not exam 2. You don't want that. That's the answer to the test. Hold on. We want the exam 2 study guide. Let's make a copy of that. So draft, right? Of exam 2 study guide. And that should have changed the name for this one. All right, so that's the one we just went over. So I'll drop that into the purine situation. So as the purine situation, there's also the phosphorus situation is different with tumor lysis and hemolysis, right? You're going to have a lot of phosphorus elevation, and thus you're going to have calcium that's low.
I don't hear that like shave off half my head.
Tumor lysis, yeah. I mean, it has hemolysis. Yes and no, because leukemias it has low RBCs, right? Because you crowd it out. You're not making RBCs and platelets anymore. You're just you use all your factory tools just to make white blood cells. So those usually are low. So you don't usually get the like haptoglobin situation, right?
So like with the ALL, CML.
He didn't die, you know, I was hoping.
Sorry.
No, you won't see hemolysis with leukemias, right? Because you've crowded them out. B12 and folate for sure, sickle cell for sure, right? Iron not so much because I mean they kind of slip by with those small tamales, right?
Just IPA,
Yeah.
low, and the rest are easy.
Yeah, IDA can have it though. I mean, it's not like unheard of. It's not as common. Just like with folate deficiency, it's not common to have the neuropathies, but you definitely can get them if you really work hard and don't eat folate. Exam 2 study tools.
I know, I needed me time.
But I'm going to test you on things that are definite. So I'm not going to test you on things that may be sometimes rare.
IPA doesn't have that, that it's rare, but the rest of them. The B12, folate, and sickle cell, they have the tumor lysis.
Yeah.
So my question is, this tumor lysis, does it cause hemolysis or is it completely?
No, it's separate.
So B12 deficiency can have TLS. I thought it's only.
No, it
hemolysis.
can't.
It's
No,
only
They're
hemolysis.
separate, right? So yeah, just to get a little chart going because they are different. Tumor lysis is associated with cell breakdown. And yes, if you have cell breakdown, that could include RBCs, but with leukemias, your RBCs are low.
No, not
Right.
with leukemia.
Same thing with lymphomas, the RBCs are low.
With B12, they would be macrocytic cells, so that would cause tumor lysis or hemolysis, right? And then.
It wouldn't cause tumor lysis because they're RBCs. RBCs don't have nuclei. Yeah, that's why I give you the basic science. So you can like, oh, that's why, right? So yeah, so I think I didn't give you the test. Let's make sure. So we could go back to.
Don't check too hard. Do you wear glasses? Because you shouldn't wear them right now.
There's draft for exam 2 study guide. It's an exam 2 study tools. Okay. There it is. All right, thank you for you guys in Zoom world. We'll stop the recording.
Someone asked, can we post the week 5 PowerPoint on the recorded version?
I started this morning. They take like 4 hours to export. So I'll upload that to see if it's done by now.
Question, how much did you pay for Snap? I did not ask her. You don't. Is it different per department?
It's not different per department.